You guys are survivors from all over the world listening right now.
All right, we are now live recording.
Okay, good afternoon, everybody. Thank you for being here. We're real excited that this is the second part of our day. We just completed our 5K. We had, I'd say, about 275 people today getting the awareness out and participating about SCAD here in San Diego, California. And it was a beautiful day. And we're here today to talk about the latest research that's going on at the Mayo. And before we do that, I'd like to bring up one of our own survivors, Marty Snyder. She's going to talk to you about an opportunity that we have at SCAD Research Inc. to raise to win $1 million. And to do that, we're going to all need all of your help, everybody that's here and everybody that's listening to us live throughout the world. So I'd like to introduce Marty, and Marty's going to go ahead and give us a quick presentation about this program that we're participating in. Marty?
Do we have slides?
Take the clicker and just click it in the answer.
Where's the clicker? Or just,
There's no clicker.
okay, so it's not me.
You can just do that too, probably.
Yes, you can.
Oh, okay.
There you go.
Okay, so again, my name is Marty. If you're on the Survivor page, I'm Snyder. That's who I am. So you can probably recognize me from that name instead. So I want to tell you a little bit about our challenge here. It's sponsored through Revlon. It's the Love Is On $1 Million Challenge this year. They do it every year. And this is the first year that we are going to do this with SCAD Research Inc. to try to raise money for research for SCAD. So I was going to wing it, but I've got something here that Jan so greatly put together so that I have something to be prepared with here. So we're excited to let you know about the challenge. It's a fundraising competition raised by Revlon where organizations that support women's health causes compete for cash prize donations from Revlon. And the charity that raises the most money will win $1 million extra toward their donation for their cause. It's going to start September 14th at noon Eastern Standard Time. For over $1.4 million to be given away in prize money to organizations participating in the challenge. So we're ready to raise as much money as we can and win the $1 million grand prize. It says $1 million, and I mentioned 1.4, and that's because there's also mini challenges week to week that we're really going to focus on and raise extra money. There's things like if you raise X amount of dollars this month, they'll match it, or there's a chance to match, or the first group to reach a certain amount of money will also get an additional $5,000. So we're really hoping to not only win the challenge, which is a big challenge in itself, but to also win some of these weekly challenges to get extra bonus bucks too. So here's how you can help. Consider joining our team as a fundraiser. By reaching out to your network of supporters, you can help us make an even bigger impact. You can make a direct donation through either the personal fundraising page or to the SCAD research page. And spread the word through social media, newspapers, whatever you can think of to, get out there publicly and get ourselves out there. Even if we don't win the challenge, hopefully we do, we're at least getting SCAD out there for everybody to know about, and that's just as big for a lot of us. Let's see here. You're going to watch, if you're on Facebook, you're going to want to watch the Survivor page and the SCAD Research Inc. page for all the updates and call to action. There is a team of us right now that are focused on getting this challenge off the ground. I believe there are 11 of us. I wrote it on my hand, but I went to the beach, so I'm going to show you what I got here. We have Bob Alico is on the team from SCAD Research. Jan Stalliard is on the team. Dave McGarry from SCAD Research, and then we've got those of us here that have organized, and that's Ellen, Robin, that is Sharonne Hensley, and then Tuesday, I can't remember her name, starts with an H, last name. We've got Ann Molnar-Taylor and Ann Fry. We've got Renee Rydberg. We've got Amber Black, and I feel like I'm forgetting somebody, and if I forgot you, I still love you. Thanks for helping. So anyways, go ahead and look for messages from us on Facebook. Check out this page. One thing I do want to mention, though, that's really important, if you want to donate to SCAD Research and you want to be part of this challenge, you have to do it through the CrowdRise website. It still counts as a donation to SCAD Research Inc. if you do it as a personal check. However, if you want it to be toward this challenge, we have to go through that website, and that's how they track the donations. So just something to know. You can set up your own personal fundraising page. It's like a pyramid almost, where you set up a page, then your friends set up a page, and anybody who donates to your pages, it all goes to the same cause. So thank you for your help in advance, and hopefully we can get this off the ground and make some money this year. So thank you.
Oh, I said. If anybody sees the clicker, because it is my clicker and we had it earlier. Yeah, so but I can do without a clicker. Yes. This one?
Yeah.
Is that good? All right. So I'm Dr. Sharonne Hayes. I've met many of you today, either while we walked or last night or in past years, and I'm here with my colleague, Dr. Jeannie Thies, who you're going to hear from later, and I just wanted to convey my thanks and our whole team's thanks for the work you are doing. I've been involved with, I'm just going to, patient advocacy. Oh, that's a good slide that she forgot to. Help kiss SCAD goodbye. And that's because it's Revlon, so they do the lipstick. But our work that we're doing, and several of you have said thank you to us, and we appreciate that. But a lot of the wind beneath our wings is the support and knowing you and having that relationship. Each of us physicians, researchers as well, have relationships that motivate them. And I will tell you that our team at Mayo Clinic is motivated because we want to do the best science. That's what we do at Mayo Clinic. We want to find answers to unanswered questions because that's really important for individual patients. But it's that extra boost of encouragement that we get and that reinforcement that it makes a difference. And that can come from you as patients. I will tell you, it has come to me recently as a provider where I'm seeing notes from some colleagues up in the Twin Cities who are great cardiologists, are great practices, and sometimes we even consider them a little bit of a competitor, a friendly competitor, because and they're recognizing SCAD, and they'll put, we're referring to the Mayo Clinic SCAD Clinic, and here's some resources, and they're putting SCAD Research Inc., and they're putting the Facebook page for their patients because we provided them. So this is one of those conditions that I would hope we'll continue to embrace the incremental knowledge that we are gaining and get it disseminated as quickly as possible. It's not fast enough, I'll say that from the start, but with your help and continued encouragement, and also the incredible funding that we have received from SCAD Research Inc., which is why we are able to do what we are doing. Honestly, you are the biggest funders of our research currently. We had a lot of early Mayo in-kind funding, and we still have a huge amount of it. But in terms of external funding, that's no match. So a lot of what I'm going to show you today in terms of updates and insights, you can take direct credit for because it has helped coming from our funding from your organization. So this is, apologies in advance. I'm not really going to apologize because some of you who are SCAD groupies have seen me and heard me talk before. And I could show you a brand new talk, but I realize that there are people who have not, who may not have some of the basics, haven't heard this. So apologies for those who've heard or seen pictures that I've shown before or heard the words, but I promise you we've got some new stuff today that's even different than May. So that's Mayo Clinic. The Gonda building is where I spend my clinical time. That's where I live on a day-to-day basis, but then a historical building that was an old Mayo building. We call it the Plummer Building now, after Henry Plummer, but that used to be the Mayo Clinic many years ago. I always start a talk about heart attacks or heart disease in women, even if it's not SCAD, about what are the symptoms, because this is important for you, it's important for your families, it's important to share with your community, because if it's not a SCAD heart attack, it may well be a heart attack of the other kind that requires urgent action. So I also like to say, everyone's heard, oh, is there women's symptoms or SCAD symptoms or men's symptoms? There are, if we look at the way men and women present with heart attacks, some subtle differences. Meaning women may be more likely to have shortness of breath and nausea. and men may be less likely to have that and more likely to have central chest pain. There's huge overlap. So I think it's important that when people are talking, it's usually not one single symptom. And I imagine most of you who've had a heart attack, you knew something felt different. It may have been those classic symptoms, the Hollywood heart attack that came in your chest and got sweaty, but it may have been something more subtle like an unusual nausea or fatigue. And so what we talk about is when you've got pain in the chest or upper, or it radiates, shortness of breath, but when these things come in combination and persist or wax and wane, that's when to think about a heart attack and when to call 911, not to call your neighbor and not to call your husband. This is an emergency. But SCAD is different, although the symptoms, the way SCAD presents, is very similar. And so we believe, as do you, that it needs to be researched differently. So some of you have seen this before, but it's a really good. This is the time course, a little speeded up, of development of plaque. So what you're seeing on that is the development of that yellow stuff, that grungy stuff, that plaque and cholesterol buildup. The plaque ruptures, and that causes a blood clot to form on top of the heart artery. And if you can see, this is a cross section. That means that the blood can't flow, causing the heart heart muscle to start dying. So you can see that might happen over many, many years. In fact, we know it does because we see early plaques and even military recruits, people in their 20s. So this is a different cartoon. So here you see a very normal blood vessel, but it splits very suddenly. This isn't something that built up or did something over decades. This is something that's the spontaneous, that's the acute aspect. And the reason that the heart blood flow is reduced is because you get this intramural hematoma there that may impede blood flow, or the flap itself can impede blood flow. So I do like to tell the story of how this research, several of you asked me, and I'm happy to talk about that. One, my personal involvement is we started our women's heart clinic back in 1998. So this was it became clear that women needed different care. We needed more research on their medical conditions, their cardiac conditions, and we needed to activate women so that they better care, had more information and could take care of themselves and advocate for themselves. And so it was in this milieu that I had an interest in this, but as well we knew that there were some rarer conditions among heart disease, not just that occurred in women, and SCAD being one of them. And that was one of those conditions that I learned about back in cardiology school, is that was really, really rare. I might see one or two in my career, and that, anyway, you know the story, you've heard that probably from some of your doctors. So this is how it started, is that in that context of being interested in women with heart disease, for 15 years we've been running an educational program for women with heart disease in partnership with Women Heart, which is the National Coalition for Women with Heart Disease. Many of you may be part of their online community. They have an online community, and several women who were in that online community, one of whom is here, I don't know, Laura is somewhere. Did she stay?
She had to ice her foot, so I don't know.
Oh dear. Oh dear. I hope she gets the red fringe out of the way of icing her foot. So anyway, you'll recognize Laura Haywood-Corey up there, but they rallied the women who were on the Women Heart website. It's a website for heart disease in women, and there's everything there. But they said they looked for that, they found them, they rallied them, they communicated with them, they got them all talking to each other, granted with screen names, they didn't really know who they were, and they came to me. So both Laura and Catherine Leon came to the 2009 October Women Heart Champion training, and I was ambushed. I didn't know. Now often the opening night dinner for this group, there's usually about 60 women. We ask them why they're here, and some will talk about their diagnoses. Not everyone does, but I do remember thinking, wow, it's a young group. There were a couple of peripartum cardiomyopathies, and 3 people said they had SCAD out of 60, right? So 2 of them, and over a coffee break, Catherine Leon said, Dr. Hayes, what's Mayo Clinic doing about research for SCAD? And I said, well, not much, actually. And in fact, it would be very, very hard to research because it's so rare that even a place as big as Mayo Clinic could probably not get the numbers that would be needed. So I just, and I puffed up a little bit. I figured I'm a women's cardiologist. I knew more than the average person. So she let me go on. And then she said, well, what would you say if I said we had found 70 women on the Women Heart website who are from all over the world? And she got me there. In that, wow, that sounded like a lot. And in fact, I went back at the end of the day and I did a literature search, and the largest case series that had been published to date at that time was just over 40 patients. So in fact, that sounded like something that maybe was doable. But remember, this was an online community. We did not have email. We didn't even have real names. They were screen names, right? And they were all over the world. So Dr. Marisha Tweet, who just went on our faculty, and many of you, if you've looked about it, she's great name, by the way, right? But also, she was a up-and-comer, really bright. I'd worked on her a couple of projects, and so she and I sat down, how would we take these, say, 70 women all over the world and even figure out how to study this rare condition? And that started a partnership with her and a developing team, because we found out we could do it through this virtual registry. We, first published just 12 patients, it was a feasibility story. And now we've got well over 600 individuals who are our part. I also know that you have several thousand who are now on the Facebook page, and so we have plenty of capacity to enroll more individuals. But that's really the story of how this all started, because people are saying, did you set out your life's career to study SCAD? And I will be completely honest, no, but it has become the most important part of my professional career, and partly because it aligns with so many other things that I've been doing. So I wanted to talk a little bit about our research and what it is and isn't, because there was a lot of confusion about a registry. Because I think early on, and some people thought, well, they'll send their stuff in and we'll send them, quote, results, or that will originally. And a registry is simply where you're collecting data and putting it, analyzing it, putting in Excel, quantifying it, qualifying it, with the hope that once you get enough DNA samples in that registry, you're on a threshold to be able to actually make some conclusions. Registries do not test a hypothesis. And by that I mean, maybe there will be a SCAD clinical trial where we'll take two treatments and we'll head them off side by side to see which one works better. And that would be, we've got a hypothesis, we think this treatment would work better than this treatment. Registries are often hypothesis generating. What that means, sometimes they raise more questions than they answer. But that's a good thing when you've got a committed research team who is ready and willing to start answering those questions. So again, I think we have already gotten a lot of answers out of the registry in terms of acute treatment and other things, but it's just kind of the start. So that's what it can tell us. So it can't answer like what's the best treatment necessarily. It can suggest that because, and I'll give you some examples later in the talk about how, gee, it seems like people who get this treatment did better than people who got that treatment. And let's see if that's statistically significant. But until you actually do a prospective trial, which is going to be the next step in what we aspire to, you won't do that. So in a participant in a registry, often you send your stuff off and you don't necessarily get updates because it's being collected, it's being sent off, it's being analyzed. And it isn't, and the way we scientists communicate is by publishing things in medical journals and presenting it at meetings. That is how that first, and the reason we do it that way is because our colleagues, other scientists and doctors then critique us. They say, well, didn't you think of that? Or, wow, that's really interesting. Why don't you try this next time? And that's how science is built. And that's a lot of what we've been doing over the past 4 or 5 years. I'm going to let Dr. Thies talk about the biobank, but just so it is a bank. We are putting the samples and storing them and freezing them. They are not like a clinical blood test that we're going to do to do that. And that was a misunderstanding early on. So as I said, we've got over 630 enrolled right now, and we've got another 60 or 40, 50, 60 angiograms in a queue where Dr. Galati or Dr. Best is reading them and once they say, yes, this is SCAD, then we enter and we send a packet to you. As you know, those of you who are part of the research, one of the unique things is that we ask you for a personal narrative. When I get to see a patient in my exam room, I ask them all the questions that I want. They can tell me their story in whatever way they want, and that fills in the blanks of the medical records. But when we're doing this as a virtual registry, I'm stuck with the sometimes incomplete medical records that are available for us to look at. And so we ask patients to write their story, which may say, you know, I really was having symptoms for 2 weeks before, but those weren't recorded in the admission history and physical. So that's an important point. And one goal is to take those personal narratives and really develop some themes out of that, because that's such an important part of it. This is most, but not all of our team, and I wanted to point out a few folks. So Dr. Galati and I are the two staff cardiologists who started really doing this at the beginning. He's an interventional cardiologist who I can guarantee has read more SCAD angiograms than anybody in the world. And Dr. Best has been a colleague in the Women's Heart Clinic and is a female interventional cardiologist, of which only 4% of interventional cardiologists are women. And we've been very excited to have that. Tim Olson and Dr. Thies work together in his lab. Dr. Kevin Cahoon, who some of you met in Chicago, joined our staff a couple of years ago. His area of interest and expertise is fibromuscular dysplasia, FMD. We'll talk about that. And he set up his own registry related to that. He also is very interested and has capacity to see patients when they come to Mayo Clinic, and has been a great resource. And then we've got people who are in training, who are in radiology, who are in OB, maternal fetal medicine, pathology. Annie Sadasti and Rachel Lindor are individuals, and we just heard yesterday, that a paper had been accepted on the experience of SCAD in the emergency room in the Journal of Emergency Medicine. So the more we can get this in different audiences, because that's an important audience, right?
Yes.
So we're looking, and Dr. Kodsey is a trainee in OB-GYN who wrote a beautiful review article on SCAD as relevant to obstetrics and gynecology and peripartum SCAD, which was just accepted by their most prestigious journal. And we were excited, and they actually made an exception because they normally don't take them, and they limit it to 4 authors. And we said, no, we're not going to have all of these, but you can't. The work was done by more than 4 authors, and they actually let a bunch of cardiologists in this OB magazine. So this was the paper on the 12 individuals, and I just wanted to go through, this isn't all of them, but to get an idea of what your support and being a part of this has helped us do. So this was a patient by Dr. Tweet, and this was that study that first said, you know, if you go in and muck around with wires and stents, you can make it worse. And maybe treating conservatively is okay, which kind of went completely against what the current guidelines for treatment of heart disease are. And that built on that. Tortuosity, we'll talk about later. Mac Alid did that. We've looked at how CT angiography and MR can help us with the diagnosis. Fibromuscular dysplasia, review articles, rehab, connective tissue disorders, and then genetic testing. And then the familial association, which I know none of you really wanted us to publish, because who wants to think that there may be, at least in some cases of SCAD, and some inheritability. But we were starting to, the more you have enrolled in your registry, the more you can understand and see, well, maybe that aunt that had a heart attack when she was 40, maybe that wasn't a regular heart attack, and maybe we should talk to her. Some work by Dr. Thies. Depression, anxiety, mood, peripartum. And then this was a great article that, again, Dr. Tweet is first author on, where it was in one of our most printed cardiology journals, where we were able to do a review on what is the best way to image in patients with SCAD. So for people who are newbies, this is helpful. For those of you who were there last night and picked up one of the brochures, some of these we had art specifically prepared for our patient education brochure. But you can see, so you've got kind of that normal artery, and then you've got the flap, which would be SCAD, or the intramural hematoma, and contrast that with the atherosclerotic plaque. This is a pathological specimen, and I don't have a pointer, but you see that purple kind of concave triangle? That is stained, that's endothelium. That's the lining of the blood vessel. That is a completely normal endothelium. And all of the pink stuff, that's a blood clot behind the endothelium. So that's what an intramural hematoma would look like in that regard. Another way we image, and I want to be clear, on the left is what we call IVUS, or intravascular ultrasound, and on the right is OCT, or optical coherence tomography. And that's a way at the time of a SCAD heart attack, if we're doing the angiogram and we aren't sure, we think maybe it's a SCAD, we can put these little catheters down and we can see the flap or the intramural hematoma. Now, we don't actually use this much anymore. We did early in our experience because we needed to validate what we were seeing. I think now we're so comfortable with knowing what it looks like without doing that, and we do know that there's a little enhanced risk. This is a little catheter that actually goes down in the artery during an angiogram, so we're not recommending that everyone gets this, but we do think it's really important when the cardiologist is doing the angiogram who says, I'm not sure what it is, maybe it's spasm, maybe it's this. This can be very helpful because it makes a difference on how one is treated. So we've said it's not atherosclerosis, doesn't have risk factors. Average age is 42, but the youngest reported case is 14. I saw that in the literature. We've had cases at Mayo who we've seen in their well into their 70s. About 80% women and about 10% of peripartum. If you look at older literature, it was more like 20-30% were peripartum. It's probably because we were diagnosing those and not diagnosing those. So it's the proportion that's changed, not the number. And the risk factors are different. It's not rare. I don't use the term rare. I say uncommon. It's a less common form of heart attack for sure, 1% to 4% of heart attacks overall. But it is the #1 cause of heart attack in women who are pregnant or recently given birth, and maybe the #1 cause of heart attack in women under the age of 50. As I said, familial cases occur. Yeah. So this is one of the graphics that came out of Dr. Tweet's recent article, where we were able to introduce to a pretty broad, largely cardiologist, of how different things can be used. I think the more we can publish and get out there and give talks, the better. And so all of these, there's a lot of ways we can look at, confirm, and infer about SCAD. So the primary way SCAD is diagnosed is with a coronary angiogram. So Dr. Jacqueline Saw, who's a friendly competitor, excellent SCAD researcher in Vancouver, who has been great because our research has been sort of side by side, and often we can confirm each other's findings. We'll say, like, I'm seeing this. We don't tip our hand too much because we want to get our publication out first. And she said, yeah, that's kind of what our experience. So I don't want to say that we're the only ones in the world who are doing research, and I think it strengthens the research to have multiple people focusing on this. But I think if you see the arrow in that demonstration, you see that little gray line there. That was what, prior to 2009, everyone was looking for. If you didn't see that, you didn't call it SCAD. You saw this staining, which is the flap and dye getting hung up behind that. So we were missing all of these who had just the intramural hematoma, and it just looked like a little bulge. And so that's what, #2, that's what we mostly see, actually, for patients with SCAD. So in this case, and I know it's pretty light in here, but you see just sort of some narrowing. 33-year-old woman, so she's had chest pain. Troponin is a blood test. It's an enzyme that your heart muscle gives off if it's injured. And it's very, very sensitive for cardiac damage. So if somebody's suspecting heart attack, you should get an EKG and a troponin when somebody comes into the emergency room. So this woman, they had some suspicion. And what we are seeing is that where the red arrows are, a little bit of narrowing compared to before that, and even down at the lower, so that looks like SCAD, but it's that type 2. But this was the very helpful OCT. I'm going to let it run twice so you are oriented. So you see that this dark bang, that's the catheter, and you see the lumen is squeezed shut. The black is where the blood flow is going through. And all of that around, I'll let it go again, that's hematoma all the way around that's smushing that artery. And down here you can kind of see, and this is as we're pulling the catheter out. So that's how we could say, oh, that wasn't spasm, that was an intramural hematoma. So then she had recurrent, remember there was an arrow down toward the bottom, and now before where we saw a little bit, and then there was an extension of her SCAD, and you see if you look on, that's the prior angiogram, she had more chest pain, and then there was an extension. So that's the other thing, is that although we like to try to treat people conservatively, meaning not going in and doing a big intervention, that doesn't work in everyone. It's actually the majority can get away with that if the artery is open. But the other part is we watch people with SCAD in the hospital just a little bit longer. So even if they're doing great, what we want to do is have them stay, so if they have this, we can go back in and do an intervention very quickly and open that artery promptly. And that was done. You can see that artery is wide open again. Although she ended up with a fair amount of metal and a number of stents. So here's an intravascular ultrasound. And what you see is the blue asterisk, if you can see that next to the circle, that's the catheter. That around the catheter, that's the blood vessel where the blood's flowing, and that dark area around that, that's hematoma. So that's what we're looking for if we do that. Here's another angiogram. I'm going to let this play. And I don't, but if you can see right up there, it's narrow. First the vessel is wide where the catheter's, and then it gets narrow. Kind of smoothly narrowed. I'm going to show you a still frame for those of you, because it's hard. But what you can see is it's narrow. So that looks very much like a SCAD because it's not abrupt intramural hematoma. And in this patient, so this is looking at some of those imaging, we actually did a CT scan. And you see she had had a CT scan that was done on admission, and they kind of missed this because it's easy to miss it on a CT scan. So on the left side, you can see this, and I'm going to show you again, but believe me, you see that blood vessels get smaller as they go down the tree. So when you see little flow before and then bigger flow, the arrows here show it helped us say that she actually had a heart attack. So but if you note, between 3 days after the heart attack and 10 days after the heart attack, that flow had been restored without needing to go and have intervention. So I think that's really important. We don't know, I get asked, how many, how do you predict, whose gets, how long does it take? We know that some recanalization occurs within days, and it may be a process of weeks or months, but we don't know the rate, but it's probably well over 60%. Just some more pictures so you can see where the arrows are. You see up there that little circle, and you see the split on the CT, that's a dissection. And these are MRI pictures. There's a condition called Takotsubo, or stress cardiomyopathy, that some patients have been diagnosed with who had SCAD. That was their initial diagnosis. And it actually can look kind of similar on the angiogram, but Takotsubo has normal coronaries, and the left ventricle recovers completely within a few weeks. So the abnormal wall motion, and so some folks have been said, oh, you had Takotsubo, but they never had the echo that showed that it had completely healed. And MRI can be very helpful in saying, no, that was a regular heart attack, not just a Takotsubo, because they look different on MRI. So I said we talk about tortuosity. That's a funny word, tortuosity. Think about Lombard Street in San Francisco or the road to Hana in Hawaii. That's tortuosity. It's a tortuous road. So this is where being able to see lots and lots of a particular condition can help us. So what we heard, what we started seeing was, gosh, when we look at angiograms of SCAD patients, there seems to be a lot more curlicue arteries than in patients or regular patients. So we took them side by side. We took age and gender matched angiograms of SCAD patients and other young women who had an angiogram. And we found, in fact, about 60+% of SCAD patients have tortuosity, compared to about 20% of all comers. So it's not that you have to have it or it's diagnostic, but it certainly is one of those potential clues. And here's what it looks like in that angiogram. On the left, you see a more tortuous, and that would be on the right, you'd see something that's more just the gentle. Yeah. So we'll talk a little bit about what we know about treatment. Our current guidelines still, although there were heart attack guidelines published earlier this year for women with heart attacks, and they had a whole section on SCAD, which was great, that differentiated acute treatment. But this is what our national guidelines are telling cardiologists like me that we need to do, and in fact, they're keeping track of whether we do it and judging our quality of care based on whether we do it. And so that is giving antiplatelets, aspirin, Plavix, putting a stent and opening that artery within 90 minutes, and putting somebody in a statin on the way out of the hospital. So you can imagine, and I say that because many say, well, I didn't have high cholesterol and they made me take a statin or whatever. I think that there's a tension here that if we know that taking, are you guys getting hot? Or yeah, I know it's warm in here. There's a tension here, and I think the important thing that we need to make through this research is that this is different, and so we need different guidelines, that it isn't just the auto. And earlier this year, they did publish them. So what do we do if we do need to open an artery? So there's stenting and ballooning, and that's called percutaneous intervention, or PCI. And then we've got bypass operation, or treating nothing. And as I told you, I alluded to the fact that people do less well with initial stenting. Sometimes we're between a rock and a hard place, and that's exactly what the patient needs. I certainly don't want to imply that you shouldn't get a stent if you've had a SCAD. If the artery is completely closed and you need to open it, the only way to do it is with opening it with a balloon and a stent. However, if you look at that artery on the left, this was it's not one of our patients, but it was published, and I think it's a really good visual. So you see on the left, that's the SCAD when they do the first angiogram. And what they see is, there's pretty decent flow down there, but it looks kind of ugly. So they say, you know what, we're going to fix that. We're going to put a stent in. So the stent opens it up, but you see proximal to that stent, it's like a little bird beak. So they then need to put in another stent, just moves that intramural hematoma back, and then, so now this individual who maybe didn't need a stent at all has got way more stents than they needed. And so that's what we are seeing, but I do not want to imply that you don't put a stent in, is just if there's good flow and the patient's stable, it's okay, and in fact perhaps preferable to not stent. And the reason that is kind of here, why the people failed, is, think about it, you've got a tortuous vessel, you've got 2 lumens, you've got this flap, and you're putting a little wire down in it. Did you get in the right place? So there's some technical factors, plus you've got more fragile arteries. So if there's good flow, we're encouraging folks, and this was the data of people who were treated, and most, 75% who had imaging showed that they had healing of the artery. However, 10%, remember I told you, had some early complications that required us to go into stent, and so that shows that we do need to stent sometimes, and maybe we need to watch these folks in the hospital just a little bit longer. And here's an example, the 2 arrows, same patient who had a follow-up angiogram for another reason, and you can see that her artery is wide open. So when I talk to doctors, I tell them you have to be thinking heart, and you have to be thinking SCAD in young patients who come in with classic heart attack symptoms. And particularly if they look at that angiogram and there's tortuosity, no plaque, no calcium, they have no risk factors, look at it a second time even if you don't see the SCAD right away. And then be free with making that confident diagnosis with OCT or IVUS. And we've even got a little algorithm that we put together and published. So I wanted to transition a little bit about what we've learned about what may cause SCAD. And I'll start it by saying there probably isn't a single cause, but there's some dominant associations, and we've got to learn a lot more about that. And I think if I could frame this, is that maybe we've got somebody with a fragile artery, a vulnerable arterial wall. Some of these things that we look for, the media, which is the middle layer of the artery, there's some overlap with FMD, which we'll talk about. They don't respond well. So this is the reason we think that there's maybe an abnormal blood vessel to start with. And then maybe there's a trigger. So that perfect storm. And maybe that trigger is hormonal in the case of pregnancy, or exercise, or, oops, almost lost the owl. Or extreme physical activity or extreme emotional stress, combination of hormones. Because certainly not everyone has this, or even a known trigger, even when they think back. And you can imagine people who have a heart attack, they think really hard about, what was I doing? I don't want to ever do that again. But that's our current thought, is this is an individual who has either a vulnerable or fragile artery, and that there's a trigger that causes it to actually then dissect. So I think that we've got SCAD in the center, and there may be some overlapping causes, but this helps me, this Venn diagram, think a little bit about it. So we've got the pregnancy and hormonal. That's the one we've known the most about, and early on that was sort of my bigger bubble. You can see that the size of the fibromuscular dysplasia or other arteriopathies has gotten bigger, because as we've learned more and looked more, that probably is a dominant association. Some patients will have a collagen defect or genetic defect. That bubble should probably be even smaller, at least right now. But then we have a lot of folks where we haven't found any of these. There's no association, and that's where the research needs to come in. So what is FMD? FMD, fibromuscular dysplasia. It is something that's been around for a long time, which we also thought was a lot more uncommon or rare than we now know that we're doing medical imaging. It's an abnormality of the muscle layer of the of blood vessels. It can occur in multiple blood vessels in the body, but most commonly in the neck vessels, in the kidney arteries, in the iliac arteries, but it can affect any blood vessel. And I was taught years ago what we were looking for was this string of beads. So if you did an angiogram, that would be the outline of perhaps the femoral artery. It looks kind of like beads with a normal on the other side. So here's a real patient. And how did we come about making this association? So one of our first publications with Dr. Galati and Dr. Tweet and I, where we looked at the 87 patients who had been cared for at Mayo Clinic prior to 2010. And they all had angiograms. And when you're doing an angiogram, a lot of times you'll shoot, well, almost virtually all the time, you'll shoot a little dye into the artery to make sure you're in the right place before you do the big injection. And sometimes they record it on the film, and sometimes they just look at it on fluoroscopy. So out of 87 angiograms, 16 of them had recorded it on the film, so we had that to look at. Out of those 16, 8 had FMD, which looks like they're over there. So then I had some patients around the same time who had findings that were suggestive of other vascular issues, and we started doing imaging, and we started finding that some of our SCAD patients had FMD in other arteries. Most was very mild. This is a pretty prominent one. The vast majority of patients with of FMD who have SCAD, you have to look really hard for it. But if you look hard, you can see the changes of it. And so our hypothesis is that perhaps they have FMD in the coronary arteries. We've known for 40, 50 years that people with FMD, their arteries are more likely to dissect or have an aneurysm or get a narrowing related to that lumpy, bumpy stuff. And so this may be a manifestation of FMD in the coronary. So it's not, so in some patients, SCAD may be FMD. I'm cautious to call this causal, because that in medicine and in research is a high bar. But I mentioned Dr. Saw and her research, and I think we came at this taking 87 SCAD patients and saying of this 50% of the ones we had to look at had FMD. She came about it because she was studying FMD. She was doing a lot of vascular radiology, and what she found is a lot of her FMD patients were disproportionately having SCAD. So that's coming at it from two completely different directions, which sort of validates, and that's what I'm talking about, why having more people looking at this gives that diversity of thought. So when we started looking at it in a more systematic way, we found that when we did CT angiography that, yeah, about 50+% had FMD, but about 70% had some other abnormalities, just little. So this was an individual who did not have FMD by that criteria, but you can see the iliac arteries with the arrows are aneurysmal. So you say, what would we need to do about this individual? The vast majority of people that we saw, we found abnormalities, we would just follow up with a CT in a year, because we're taking a snapshot here. This may have looked exactly like that for the past 20 years, not changed or anything. We don't want to get overexcited and go in and do something, because of course this has not been imaged before. So this is some of the artery beds that we can see in terms of fibromuscular dysplasia. And this is a slide from Dr. Cahoon I mentioned earlier, because as he's looking at his FMD clinic, and we correlate with all of these other clinics, because we have a little bit in our vascular. If you have FMD from the neck to the head, you see neurology, and if it's from here down, you see our vascular medicine people. We all talk to each other, but that's how we divided the body. And obviously some people have it in both places, but and that's why we have an FMD clinic. That's Dr. Cahoon. You can call the main Mayo Clinic number. We'll give that, but if you have an interest in FMD appointment or being part of his research. So the implications if we have SCAD or identify FMD is we recommend that we get and this is what, not just we, but those who are experts in FMD, they say a one-time scan of the blood vessels from the top of the head to the pelvis. We've developed a protocol where we do neck and head and abdomen and pelvis in one sitting with a low dose, and we did not have a lot of uptake on the chest. There are a couple reasons. Many people who come in with SCAD actually get a chest CT angiography because they're being ruled out for a dissection or a pulmonary embolus. So many folks had already had that, and it was normal. And two, we looked back at our retrospective and we didn't find anything new in the chest on folks. So we address any findings, and most of what we have found is extremely mild. And so you say, why? One question I get, so why should we do the imaging if you're not going to do anything about it? I think that's a really good question. And I think you should ask your doctors and you should ask yourself. One, there may be some discovery that's directly related to FMD that you would want to be aware of if you have the condition, so that would be one. And since this may turn out to be causal, but you're right, if you say, I don't want to have another procedure, I can't afford it, whatever, I think that people will, I will be the first to say that the evidence wouldn't say we should go out and screen everyone who's had a SCAD, although that is our practice because we do believe that that's probably appropriate. And one of the reasons is if over 50% of people with SCAD have FMD, and we know that that means there's about a 4 times increased risk of baseline of a brain aneurysm, having that brain scan to make sure that there's not something else that needs to be done, we think is justification in itself. Those of you who were here last year, this was birthday candy for Ellen last year. So I want to talk briefly about familial. So we reported 5 familial cases. We've now collected about another 10. And recently a brother-sister. All of the familial cases prior to that had been to female relatives. And so we have reported that. We are obviously very interested in understanding and having the DNA in those families. So with that little intro, I'm going to have Dr. Thies come up and talk about the exciting things that we're doing related to your DNA samples.
Good afternoon. It's a privilege for me to be here to speak to all of you on behalf of the genetics team. And I'd like to thank Ellen for the invite, and I'd like to thank everybody here for the inspiration that you provide to me and to our team on a daily basis. So what I'd like to do today is to provide you with a little bit of context for how we're thinking about SCAD genetics, and I'll do that by kind of giving you a little bit of a backdrop, and then I'll talk about some of the things that we're doing right now. So since we started looking at SCAD genetics, our hypothesis has been the same, and that is that there are some genetic factors that underlie susceptibility to SCAD. So in order to address this hypothesis, we have two aims in place. The first is to create a DNA biobank for individuals with SCAD as well as their parents, and then to use that valuable resource in the lab to look for and identify inherited and spontaneous mutations in the individual who's had a SCAD event. Long-term objectives that we have, this is our dream. We dream about this when we're going to work and working on this every day. So that is to discover the biological mechanisms of SCAD. So by finding the variants and looking at the genetics, can we determine what's happening within the coronary artery wall? Is there a pathway? Is there something that's amiss? And using that then to maybe someday develop tests and treatments to predict, and ultimately the dream would be to prevent SCAD altogether. So it's become a tradition to show a map to illustrate the study participation. Each teardrop that you are seeing indicates an individual who has provided a DNA sample for the SCAD genetics. So 506 study participants in the United States. Impressive number based on what you just heard Dr. Hayes talk about in the beginning. But what's almost as impressive to me is the breadth, and that's why I like to show the map. We're not clustered around the Mayo Clinic in Rochester, Minnesota, and that's what you and SCAD Research Inc. has done. The awareness that's being raised has brought people from all over the country looking for an answer and helping us by participating. So being a scientist, I like pie charts, and so this is a pie chart to represent the data, and this is showing representation of the top 10 states, so Minnesota, Illinois, and California, and you can see the number of individuals and the percent of the total. So as you know though, and that social media is not confined by the border of the United States, so we do have international participation as well. And shown here is showing the world, and now you see that still having the teardrops as participants, many in the neighbor to the north in Canada, but also overseas in Australia, New Zealand, Holland, Italy. And again, just showing you kind of a breakdown if you're curious about how that breaks down in terms of the countries. So where do we start? Where we start is where you have all brought us to this point of having the DNA samples to begin looking and begin searching for answers. So if you add those two slides up, there's a total of 535 individuals who have, again, provided a DNA sample, which is securely stored in our freezers at the Mayo Clinic. Over 90% women, 15% with recurrence, and the age at initial onset anywhere from 20 to 75 years. For reasons I'll make known in a few slides, we are also recruiting parents of individuals with SCAD. And right now we're at 369 mothers and fathers of those 535 who have also provided a DNA sample for this study. As Dr. Hayes mentioned, familial SCAD has come to light over about the past year or so. And what you're seeing on the screen is what we call pedigrees, and this is the language that we speak in our lab. So I just want to translate it for you because I'm going to be showing a few more pedigrees in subsequent slides. So squares are males and circles are females. A horizontal line combining a male and female would indicate marriage, and then the line coming down and branching out indicates the children. Black symbols would indicate an individual affected with SCAD, and white would be unaffected with SCAD. So the top four pedigrees that you're seeing are all two sisters who have had a SCAD event, and all of these families are participating in the genetic study, so we do have DNA samples, again, stored in our freezers. So to kind of give you an idea of how we're thinking about SCAD genetics, I wanted to give you two very unique blood vessel disorders in terms of their genetic underpinnings. So on the left-hand side is Marfan syndrome. This is a connective tissue disorder. One of the features in many individuals is an aortic aneurysm, which is shown at the bottom. And now if you look at this pedigree, you'll see that this is a little bit different from what I just showed you. Here we have multiple generations. You can see many colored symbols indicating many individuals with Marfan syndrome. And this is very suggestive of a hereditary syndrome, something where there's just a single variant that causes it. And in fact, the genetics of Marfan syndrome has been solved. It is known to be due to a variation in a single gene. So anybody that presents with Marfan syndrome, their clinician can recommend that they have this specific gene screened so that they can then know that specific mutation that led to it. So the blue background, hereditary, single gene. On the right-hand side is atherosclerotic coronary artery disease, and Dr. Hayes also showed many nice pictures of this. Shown here is my little cartoon I have showing the plaque buildup. This is a disease that's thought to be more due to environments, so high cholesterol, bad diet, things like that that could come together. However, there are some population-based studies that have shown there are genes, there are variants that are associated with this disease, but these variants would play a much more minor role than the single mutation in Marfan syndrome. So there's environment and many genes that maybe come together for this. So a lot more complicated from a genetics perspective. So we view SCAD as being somewhere in the middle of this. Based upon there being familial cases, is very suggestive that there is a genetic basis and a variant or variants involved with the SCAD event. But there's also many spontaneous cases where it's just a single individual in a family. And so that's where we think this kind of bridges those two different blood vessel disorders from a genetic perspective. So where do we begin? And how do we begin to unravel the genetics of SCAD? The technology that we're using right now is one that's known as whole exome sequencing. Whole exome sequencing is a platform that's been around, available, and affordable for maybe the past 5 to 10 years. So it hasn't been around for a very long time. And what it does is it takes the entire DNA sample and it extracts those genes, all the genes that are in the DNA, so that encode for proteins, extracts all of those and then it reads them. Reads all of the genes and it identifies any variation that's different from what we would normally expect to see. We all have millions of variants in our DNA. That's what makes us who we are. That's what gives us the color hair and how tall we are and all of that. So we all have many variants, but the key is finding the variant that is the one that's linked, in this case, to SCAD. So it starts out with a sample, a blood sample, a saliva sample. We take that, process it, extract the DNA from the sample, and then it goes through many processing steps, which probably takes a few days. And once it's been processed and is ready for whole exome sequencing, we then put it on an instrument like the one that you're seeing in the picture in the middle there. Once the processed DNA gets on that instrument, it takes about 5 to 7 days of constant data collection where the same DNA sample is sitting there and the instrument continues to collect data during that entire period. So as you can imagine, that generates a whole lot of data. And so that's where data analysis comes in, and we work very closely with our bioinformaticians and our biostatisticians to help to take all of those pieces of sequence data, get them all aligned the way they need to be, and then annotate all of the variants. So all said and done, when you look at those 20,000 genes, there are about 1 million variants per individual that we will identify. So this is where we come in. So we get to start looking at those 1 million variants and try to figure out which ones are the ones that really matter for SCAD. And we have many filters that I'm going to that we employ. I'm not going to talk you through them because I don't want to put everyone to sleep here. But two of the things we look at is we look at the rarity of the variant. So many of those 1 million variants are very common. You'll have maybe 50% of the population has the variation at that specific point. those are ones we don't care about. So we can filter those out. We also look at what kind of an impact that variant has on the protein. And so we have many different things that we look at. Again, I'm not going to take you through any details, but we're getting smarter as time goes on, and it's amazing just, even from a year ago, the things that are coming around that help us to filter those variants down to what we would call the SCAD susceptibility variants. So in terms of advances, so I'm going back 2 years ago and thinking about our DNA biobank. You can see the growth from 2014 to 2016, so nearly doubled the number of samples. And this, I should say, is from last week, and I can already tell you this is no longer current. I know that there's a few more DNA samples that have arrived at Mayo, so this number continues to creep up weekly, which again is a testament to, the awareness that's being brought. Parents of SCAD participants has also over doubled, and then familial SCAD, like I showed you those 8 pedigrees that we have DNA samples on. In terms of the sequencing data, so going through that technology, we have now had 50 SCAD participants where we've done whole exome sequencing, and 88 mothers and fathers of those SCAD participants who have also undergone whole exome sequencing. So you can imagine the number of variants if you add up those. And then gene filtering. So going from the 1 million down to the susceptibility variants, there's huge advances in the field because everybody is, the technology is literally racing at lightning speed. Things are becoming cheaper, faster, more people can do it, you can generate more data, and so there's more things to look at, and that helps us in this filtering process. So population control sequences are essentially individuals out in the population that have undergone whole exome sequencing from different research groups, from different programs, the Thousand Genomes Project, different things that have brought together these data sets. And many individuals from around the world have actually brought their data sets together to make them publicly available. So if we find a variant that we're interested in, we can immediately go and see how common is this out in the general population. In 2014, there were 6,000 available. By 2016, there were 60,000 individuals available to use as controls. Genes specifically expressed in coronary arteries. So this is another thing that when we have that list of variants and those list of genes, if we can know that, yes, this gene is very highly specifically expressed in the coronary artery, that would also help us to know that maybe that does play a role in the SCAD event, and maybe that artery is more fragile because of having this gene that has a variant in it. So in 2014, that was unknown. By 2016, this is a known with a lot of technologies out there and people that have looked specifically at the different layers of the coronary arteries and identified the genes that are highly expressed there. So we can now use this as another filter. So our pilot study design, starting out with those 50 individuals that we did whole exome sequencing on, was really family-centered. So we would do whole exome sequencing on mother, father, and the individual with SCAD. And here what we're looking for, we do several different filters. One is sporadic. So this would be looking for a variant that's in the individual who has had a SCAD event but is not present in mom and dad. And this is not very common. But nearly all of the variation in your DNA would also be found in mom and dad. So this is not something we see a lot of. And with whole exome sequence, there may be 1 to 5, what we would call sporadic or de novo changes that are not in mom and dad. Familial is the other approach with the family-based, and this is looking at those familial cases to see if there are variants that are shared between those individuals that are not in their mother and father, or maybe they have an enriched burden of variants in a certain pathway that might be important in the coronary artery. So this, as you can imagine, has yielded many candidate genes from these 50 individuals. So we're, like I said, we're collating our data, and as we generate more data, we can go back to this to help to strengthen those candidate genes. So what we know right now is that there's genetic heterogeneity. What that means is that there's no common SCAD gene. We've also learned by looking at the commercial gene panels for aortic aneurysm and dissection that is not equivalent to SCAD from a genetic perspective. So there are likely different genes and pathways involved in the two. And out of our several candidate genes, there are 3 genes that fulfill the most stringent filter and are highly expressed in the coronary arteries coming from the familial cases. So these are ones that we are actively working on. And the way that we're working on those is we're working to validate those top 3 candidate genes. So we've done whole exome sequencing on 50 individuals, but there's 485 other DNA samples we have in the biobank. So what we're doing is we're taking those 3 candidate genes and we're screening the other 485 study participants using a different technology that I won't talk about today. But to see if there's other variation in those genes that might make it more compelling. And another thing we're actively doing is looking at the subtyping. And so this is as we get more sequences and we can start to group individuals based upon the beautiful clinical registry, based upon pregnancy, recurrence, fibromuscular dysplasia, and look at if there's different variation in pathways in one over the other. So this is actually new from when I was up here in Naperville, and this is a really exciting project that we're currently pursuing. We're in the early stages, but it's known as a genome-wide association study. With this study, this is something that can only be done because of the number of individuals who have participated. So this study is really prohibitive if you don't have many individuals. It's something we couldn't have dreamed about before now when we look at the numbers and see that we have over 535 individuals. And the reason for that is because what you're looking for is enrichment. So on the left-hand side, you see a whole bunch of circles and squares that are colored indicating individuals who have had SCAD. And on the right-hand side, we have a control population who have not had SCAD. And so where I've colored the teal circles and squares would be looking at a specific signal that comes out. So we generate a lot of data from this, and then we compare and do a lot of statistics to compare those with SCAD and those who have not had a SCAD event. And looking, again, for sort of that signal that would then guide us to a specific region. So since I have kind of shared with you 2 very different technologies that we're using, I thought I'd do a little side-by-side to give you an idea of what do the 2 do and how are they different. So for the anticipated result with whole exome sequencing, we're looking for the cause of disease. We're looking for those very rare variants that shouldn't be around, and based upon all of our filtering that would look like they could be a cause. With the genome-wide association study, we're looking for a marker, and so we're looking for something that would maybe help to guide us to a specific region where then we could maybe find that causative variation. The cost per individual is also quite different. So for whole exome sequencing, it's $1,000 per individual. For a genome-wide association study, it's about $125. And the required number of cases, this is the big one, and again, the reason we can do this, with whole exome sequencing, you can perform whole exome sequencing on just a single individual, as many as that you want. With the genome-wide association study, the lower threshold that is set is 500. So like I said, this is something, we're in the early stages. We have not yet drawn the line in the sand. Once we have the subset that we're going to move forward with, then we'll proceed. But we're hoping within the next 1 to 2 months that we will be able to get that rolling. And so again, these are, one is not necessarily better than the other, but they do complement one another very nicely. So this is my final slide. I'll leave you with one pie chart here to go. So our ultimate goal in all of this is to do whole exome sequencing of all participants. So we've done 50 individuals. Currently with the 535, there's 485 individuals who have not been sequenced yet. And with your partnership, with all that you do, and the passion that you bring to us on a daily basis to keep going. We're excited, we're confident that we'll be able to hopefully soon have some data to share and bring some more answers to you.
Thank you. I learn something every time she gives me a talk. So, and it was a little technical, and I know some of you have clinical questions, but some of you are really data geeks and want to know really the nitty-gritty, and that's why we're trying to provide you that today, a little bit of everything. So I'm going to end, just take a few minutes before we start taking questions about kind of that clinical. We had the virtual registry, and we didn't think we'd get people, you know, we thought they'd mail things in. But what happened as we started doing more research and publishing, and so patients started coming, and we realized, well, that's having patients seen in a SCAD clinic, having them go through certain tests, reviewing them in a consistent way, and building a clinical database was going to enrich what we were doing in terms of DNA. It was going to enrich for those patients who were already in the registry. We then had a lot more that we could go on. And we doctors are not computers, which means we cannot spit out millions and millions of data. On the other hand, some of the best computers are those, I've now seen 10 patients with that same story, or with that same angiographic appearance, or with that, and there's nothing better for us than being able to talk to patients. And so that has brought forward a lot of some actually discoveries, but actually some just hypotheses that then we can use our rich data to test. And so that's how this all puts together. So when I told you about that 87 patients that we looked at retrospectively, that amounted to all of the SCAD patients we had seen in the 15 years prior to 2010. So you figure that's about 10 a year. So now we're seeing about 10 to 12 a month. So you talk about exponential understanding of a condition, both in, you know, and how to treat a condition for which we don't have a lot of guidelines. That's been very helpful. So I'll leave a few pearls, because one of the things that I would tell every single SCAD patient to do is participate in cardiac rehab. I know you may be the only girl, you may be the only person under the age of 40, you may be, they may ask, they think you're one of the staff because you look too healthy. But I can tell you the data on cardiac rehabilitation after heart attack is so compelling in terms of its return on investment, both of time for the patient and hospitalization and mortality. That alone is the reason that you should go. And then the other is that people think of rehab, even some of your doctors think of rehab as, oh, you're just going to go and learn to exercise again. And they look at you as a healthy looking person and they say, well, you can go do that on your own. Well, let me tell you, those of you in this audience who have had SCAD know that you don't do anything on your own, because you've just been hit by a ton of bricks. And even if physically you are feeling okay, which is not always the case, you're probably an emotional basket case. And I say that because we have the data to support that. We know that if you take all comers, heart attack patients, this is not just SCAD, take all comers and we survey, not, do a test, 25% of people who are in step-down units after a heart attack have depressive symptoms. And then we look at who are the ones who are most at risk for it sticking. It's women and people under age 60. So who gets SCAD? So if you have people that you know who said, my doc said I didn't need it, or I went and it didn't seem to meet my needs or it wasn't worth my time, then make your needs known. Cardiac rehab staff generally are excellent. And don't let those old gray-haired men scare you away. In fact, many of them have talked to me. I mean, many younger women, and I care for a lot of women, not just with SCAD, and they say I was the only one, but they treated me like that was their granddaughter, and I guess that was okay. So I just really want to talk about rehab, and that should be a consistent message. So in terms of having SCAD, people say, what drugs after SCAD? Remember I said what we don't do automatically. Well, right now, aspirin we recommend, aspirin we don't believe prevents a SCAD. On the other hand, if you have a heart attack, aspirin limits the size of a heart attack. So if you were to have a recurrent SCAD, being on low-dose aspirin, but there's not a huge amount of evidence for SCAD specifically, so if it really bothered your stomach or you had a lot of bruising from the baby aspirin, I mean, I think that you have to use some judgment. But that's the one that we typically use. If you get a stent, then you need to be on dual antiplatelet therapy, and that's aspirin plus Plavix or Brilinta or one of those other medications for at least a year. There's some controversy about whether somebody who doesn't get a stent should be on Plavix or Brilinta for a period of time. Certainly, I don't believe it should be for a full year, but I think many of us are using it for a few weeks or a month or so in that early healing. But when people ask, what should I be on because of SCAD, the medications, we use a lot of cardiac medications for other things. So if you have high blood pressure, if that's discovered, then being on medication to control that is probably even more important in SCAD. If you have reduced heart pumping function, there are guidelines for the types of drugs, ACE inhibitors or ARBs plus beta blockers, that you should be on because of, not SCAD, but because of the effects of SCAD that it had on your heart. And it may be that if you have that early support, early after a heart attack, your heart pumping function will improve enough that you can go off of them. The other big thing is right now, and I say this, we don't recommend routine statin therapy in patients who have SCAD. And that's probably the one that's most different from the current guidelines for heart attacks, and probably the biggest one to get over for doctors, because I'm a pro-statin person. I will go to the mat for my patient who really needs it and meets criteria and is saying, no, Dr. Hayes, I really don't want to take it. But that's because I have oodles and oodles of evidence that in somebody who has plaque and atherosclerosis, that statins do a lot of things, both reducing cholesterol, stabilizing plaque, reducing inflammation, a lot of things that directly, and we have a lot of data on that, millions of people, hundreds of thousands of people. We don't have much data on statins. Statins, even if we think about how they work in the body biologically, we wouldn't expect that they would prevent SCAD. And we had this little signal in that 87 retrospective look, and again, that's a small number considering the millions that we understand about with atherosclerosis. And it's not one we even looked at. So we sent our manuscript about these 87 patients, our observations, to the journal, and the reviewers said, what about medications? How does that figure in? So if you want to get your paper published, you have to respond to the reviewers. So you go back and we reanalyzed all of the medications that SCAD patients were on. And what we found was very slightly, but definitely, and again, the small number, there was slightly more recurrent SCADs in patients who were on statins than those who were not. Do I believe statins are harmful? I actually do not. I think this was too small a number. But what I believe is they probably don't prevent recurrences. And that's what we put people on statins for after heart attack. It's prevent a recurrence. It's not lower cholesterol. One of the ways it does that is by lowering cholesterol. So we do use statins, and if you've had SCAD and you have high cholesterol, you may well need a statin, and we don't think it's harmful. And in fact, but we use a different criteria. Instead of for secondary prevention, where we say everybody gets a statin, we use statins selectively in people who have high cholesterol that otherwise are at risk for atherosclerosis later in their life. I'm going to talk a little bit about a very common symptom after SCAD, and after heart attacks in general, but more commonly after SCAD, is having persistent chest pain after SCAD. So chest pain syndromes after any heart attack are concerning to the patient. They're concerning to we doctors. Does it mean that there's been progression? Has the stent blocked off? Has there been another heart attack? Did we not open enough arteries? So this is not unique to SCAD. But my experience, and again, we're sort of trying to look at that data, is that it's a bit more common in people after SCAD. Now, again, there's some overlap. Remember that intersectionality. We know that women, younger women, have more chest pain anyway. So we take a group who's had a bad event, and then they have persistent chest discomfort. So each one is very different in terms of that. So there's a lot of potential causes, and I will tell you some of those that I have found in patients. So it may be non-cardiac at all. It's chest wall. I can find the pain by pressing on the chest. The patient can too. They jump off the bed and say, oh, that's it. That's really scary to have after a heart attack because it's chest pain, but it's not heart pain. And trying to address that local pain through stretching, through rehab, through analgesics is really important, because think about it. You have GERD or you have chest wall pain and you're worried about your heart, that's always going to be a distraction. After any hospitalization for any cause where you're in for any length of time, people become more attuned to their bodies. Because what did the nurse ask you about every 15 minutes? Can you rate your pain? Can you tell me how you're feeling? And so you start thinking about that all the time. That's human nature. That does get better, that hyperacute awareness of every bodily function, some of which you may have had long before your SCAD, but you lived with it, you didn't even notice it. So that's one of those, you can't just assume that, but that's one of those good outcomes. So in people who have, what we do as good doctors is we listen to patients and we take the history and we listen to when they get it. So if you get your chest discomfort after exertion all the time, that's the main time that you do, that suggests that maybe there's a persistent blockage. Maybe the stent is narrowed. Maybe there's been something. So every time I go up that hill, I get this chest pressure. That we should evaluate with some type of stress test generally, because that can be very helpful in saying this is heart or not, and even where it might be. So often we'll get a stress echo. And when we're looking for that, we're looking how far can that woman or man exercise? What symptoms do they get? What does the ECG do? What does the heart rate and blood pressure do? And a number of other factors. And if that's abnormal or positive, then that may be a mechanism where we would either treat with higher doses of medication or perhaps take that patient back to an angiogram to see if maybe the stent was narrowing down or there was a problem with it, more SCAD. Now, then we're left with patients who have what really sounds like heart pain. So they get chest pain that they can walk all they want, they can jog. But if they get mentally stressed or some other triggers, they will get chest pressure and pain. And if they take a nitro, it goes away. And that to me is a pretty good diagnostic test for, not definite, but that probably means that that individual has chest pain that's due to the heart not getting enough blood. So why might that be? Well, this is after we've already excluded a fixed blockage. That's important because we have a specific treatment for that. So it may be that during the healing of the artery, which has been damaged, remember it's split, so it's got some healing to do, it's irritated and it's more likely to spasm down inappropriately. Now there's a condition called coronary vasospasm, and often people will get it randomly or they'll get it with mental stress. And so in a patient who says, so I'll sometimes say, well, next time you get it, take a nitro and see if that makes it go away. And if it goes away within 4 or 5 minutes, that to me speaks it's probably cardiac, and that maybe they'd benefit from some type of medication that would relax those arteries. And the two classes of medications that we use are nitrates, long-acting nitrates, and calcium channel blockers. So like Norvasc, amlodipine, or Imdur, isosorbide mononitrate. And often putting individuals, so this is where I have a little pushback from my own scientific brain, because we're calling this empiric treatment. Empiric treatment is, you've got a pretty educated guess that this might work, but you've got really no data and you don't know exactly what's going on. And anytime we doctors do empiric treatment, we need to make sure that we're not causing harm. Unfortunately, those two classes of medications, their side effects are predictable, they're short-term, and they don't cause much harm. So nitrates, it's mainly headache, sometimes unbearable, sometimes it triggers migraines, and we may need to back off, but it's a pretty benign medication. Calcium channel blockers are also used as blood pressure medications. So one risk is we lowered the blood pressure so much that somebody got woozy and, you know, and passed out. So that is an approach that we and others have found can be very beneficial to patients with chest pain after SCAD. Now, what I tell patients, though, is if you start this medication and it makes no difference, that's a little bit of a diagnostic test in and of itself, because maybe it's not cardiac. And so I think that this is a little more of that art of medicine than not. Again, if there's an abnormal stress test, we take to coronary angiogram. I'll talk only briefly about pregnancy. We do, because of the association of SCAD with pregnancy, we generally advise people, 1, not to get pregnant after SCAD, and 2, to use an effective and non-hormonal form of birth control. So IUD, partner sterilization, dual barrier. And there's a lot of discussion among our SCAD survivors. Imagine telling a 45-year-old woman who's had 4 children she shouldn't have another one. She might say, that's sad, but I wasn't really planning it, or I guess I won't have a 5th. Imagine telling a 22-year-old who's not married, we don't think you should have any children. We need to figure this one out. What are the real risks? So we know that SCAD can impart a risk, but it may be a very narrow, it may be a different group. And right now, we're having to give this sort of broad recommendation or to avoid pregnancy. And I think this is something that we need to better understand, and some of that is better understanding the mechanism of why it happens during pregnancy. Is it the hormones? Is it the pushing? Is it the fluxes of hormones? And that's what I personally believe it probably is, because we have patients who have planned C-sections who've had a SCAD. So this is not the labor itself, we don't think. So this is an area that our current recommendation is don't have a pregnancy, and that would also include, because some have come forward, well then, can I have a surrogate and then have my eggs harvested? Well, that requires a fair amount of hormones. And I'm concerned about that. It isn't just the pregnancy itself. So I think a lot to learn in terms of this. I will say that the vast majority of patients who have had peripartum SCAD are older mothers, so late 30s, early 40s, and it is not their first baby. That is they're usually older, and it's their 2nd, 3rd, 4th, or even 5th pregnancy. So these are just some of the other things that we address in clinic. Some of you have asked, we do think that migraines may be more prominent in SCAD patient population. That may be relevant since migraines are a vasospastic condition and are more common in women. And we're going to take a deep dive in this next few months on the registry to see if we can correlate that. The last one, support for me and my family. SCAD Facebook page, Women Heart, the National Coalition for Women with Heart Disease, SCAD Research, Inc. All of those look to one another, because you may not have that support of a SCAD sister, so to speak, or a SCAD brother in your cardiac rehab or in your community. So I think to summarize, we want to make sure that doctors out there are making the diagnosis, making the correct diagnosis, and treating it as SCAD and not like regular heart attacks. We're going to continue to look at all of these things. Who's getting it? What are the risk factors? What are the ones we haven't even discovered yet? And I think an important thing would be, what is the actual prevalence? People ask that, say, you know, what is the actual prevalence? And we don't know that because of the way we collect data. You know, so you take one segment, it says, well, 1 to 2% of all angiograms have SCAD. Well, that's not all people with a heart attack or all people. So again, we need that. And we announced it in May, but we're in the deadline, rolling deadline period. So a large group of experts across the world, actually, because we've got Dr. Adlam in the UK, are working together to prepare an American Heart Association scientific statement. That is different from a guideline. A guideline is a higher bar. That means you have you've got lots of evidence to inform how we do. So a lot of the wording in here is you may want to consider, but it will be a review of it, and that's big because that gets into every cardiologist's mailbox. And yours if you want to print it out and take it to him or her. So we started the clock in June. The process is a pretty rapid iteration. We're a little behind because of summer, but this is supposed to be in print a year from the time we had our first phone call, so look for sometime next year, mid-year. And there's some really great hospital systems and expertise from genetics, and we were thrilled that we actually had 3 Mayo Clinic cardiologists on there. So we've got a website. We've got our CEO who's standing next to me, who's willing to wear a red tie on National Wear Red Day and talk about SCAD. So, and he'll even reference our research because he thinks that whole patient-initiated research that's being done at Mayo Clinic is something really to be proud of. So I will be glad to take some questions. Remember that you're being recorded and live streamed, so you just remember that. You're sharing it with the world. So in terms of what questions that you ask.
We have a couple questions that are live.
Okay, so we've got some live streamed questions, and so we'll take one or two of them, and then we'll see hands.
All right, so the first one we have, well, there's only one currently on. Deb asked early on in conversation, she's curious if coroners are being educated on this.
Coroners.
Yes.
So really good question. We are trying that because I think SCAD can be missed on an autopsy, and here's why.
Can you ever repeat that question?
Okay, to repeat the question, sorry. So are coroners, so those who do autopsies, are they being educated on this? Two comments. One, SCAD can be missed because often it occurs in the distal or the far out coronary arteries down at the tip of the heart. And if they see pristine, normal coronaries up when they do that first dissection or they look at the heart, they may not look farther and do the sections. So we do know that it could be missed. The other part is coroners do not have many resources. They are often, in fact, they've got less resources now than they did 10 or 15 years ago in terms of their county coroners or city coroners or state coroners. And so one of the things that we are doing is making a kind of it's a little bit fudging, but our cardiac pathologist, whose name was up there, is willing to look at coroners and consult with coroners who have questions about patients or who make the diagnosis of SCAD and want to know more or what they should do. So it's more of a dissemination. Take question from the audience. And I'm going to repeat the questions for those online. So I'll take the...
This is an easy question. A lot of us wear a band that people can go online if something happens to us that the ER docs can be directed to our people. But I've heard often recommended that we should have our whoever's treating us consult with Mayo. What phone number should we use?
Oh, yeah. So the comment was many people are wearing, whether it's a band that has a link to your electronic record or a medical alert bracelet or something like that, and that's one. But if people would like to talk to a SCAD expert at Mayo Clinic, we are, if available, happy to talk to doctors. And the best way would be to actually probably call the main Mayo Clinic number, which is 507-284-2511. And if it has to be kind of so that number is answered 24 hours a day. My secretary's and all of ours is 8 to 5 Central Time. So that's when, and so they will take and get that number at 24 hours a day.
What was the number again? I'm sorry.
507-284-2511, and that is the General Mayo Clinic number that is answered 24 hours a day. People can ask for Dr. Hayes or a colleague, but I probably, if I'm away, we actually have a little triage set up just for this, that if they call for me, but they can also get Dr. Galati or Dr. Tweet or Dr. Mulvey or a number of people. So we know who there is to take those calls. Yep.
It looks like you want SCAD to be recognized under American Heart Association. As we move forward towards that happening, will we or SCAD ever be supported in their funding? We cannot receive funding, is that correct?
So the question is, American Heart Association, if they're going to recognize it, do we get funding for it? So they're a little bit different. So if you think about American Heart Association is they fund a lot of research. They're also a huge fundraising elephant because they're funding a lot of research and education, Go Red and the like. And I have, along with some of my colleagues for many years, have tried to advocate to fund more research on heart disease in women in general, largely because they raise a lot of money on the backs of women and with Go Red luncheons and the like, so really looking at that. Their response has been a bit slow but gratifying because this past year they had a call for grants, which would be centers of research. Now, the SCAD didn't fit very neatly under this. It was a big investment by American Heart Association, and Mayo did go forward with a proposal that included SCAD, but they wanted basic science, population science, and that's a little more challenging with a rarer condition, and clinical science. So we made a big, great faith effort. We, Mayo, were not funded, but I think AHA is increasingly looking at ways to do that. And we will continue to apply for appropriate grants. HA tends to, their position, we're going to fund the best science, and they don't usually say we're going to fund heart failure, we're going to fund SCAD, we're going to fund a specific entity. That hasn't, in the past, they haven't had focused research like that. And that's where an organization like SCAD Research Inc. is so important, because until you can raise enough awareness among the general scientific community that this is important, there are huge knowledge gaps. That's actually when you get the bigger players, the bigger funders, like an American Heart Association, to say, oh, this looks like something that we need to do to move the science forward. So, yeah.
You referred to migraines, which a lot of us have, myself included. And I know that before SCAD, a lot of us took triptans, and after SCAD, we're advised not to take triptans. So is there something that you do recommend that your migraine SCAD patients do take?
So the question is from a patient who has migraines and had SCAD, because they seem to be common, and then after SCAD, one is told not to take triptans, which is a type of drug that we use to treat migraines, and is often a very effective drug. Triptans work by causing vasoconstriction or narrowing of the arteries. In fact, the main side effect of triptans is people who get, and people not with SCAD get a little chest pain or get some palpitations. So in general, we cardiologists and the neurologists would say, gee, we'd like you to not take triptans. So I would agree with that. We're fortunate, there are a number of prophylactic and other medications and I'm not a migraine doctor. And what I recommend to patients who we've just taken away their lifeline or their effective treatment for migraines is that they actually see a specific headache doctor, which often takes some iterative trying of different drugs like Topamax or nortriptyline. I've actually had a number of patients whose migraines went away after SCAD, because perhaps they were put on a beta blocker, which is actually a very effective prophylactic drug for migraines in some patients. So I think it's an individualized thing, but I guess the bottom line is I agree with avoiding triptans. Got one in the back.
So my brother has been emailing me information about supplements and strengthening your arteries. Is there any way to do anything like that? Or anything?
Yeah. So the question is, are there any supplements that have been shown to strengthen arteries or that SCAD patients should take? The short answer is no. That we get excited about supplements in terms of whether it's preventing heart attacks or cancer or whatever, and then when we actually start, because often the supplements are formulated based on, okay, this group of patients or this population eats or has a high intake of this particular entity, and they have healthy arteries. So maybe if we take that entity, that drug or supplement, and we start giving it to people, it will improve that. And we do that. We thought that on vitamin E. We thought that with beta carotene for lung cancer. And then when we actually tested it, we found that it wasn't that individual supplement. It probably was the pattern of eating or intake of that population that made their arteries so healthy, that it was more complicated than a single supplement. So I would use caution, because I have had a long career in cardiology and medicine, and I've seen supplements that had great data in observational trials saying, well, in this population of patients, it made them less likely to have X, Y, or Z, and then when we actually prospectively tested it, it didn't work. And in some cases caused harm, like vitamin E at high doses, it actually increased the risk of heart attack. So we said, don't take that anymore. Fish oil is another one that we used to prescribe after heart attack, not SCAD, just regular heart attack, and now we don't see much benefit, not really harm, but and so that's a long way of saying most are probably not harmful, and some people feel some benefit, and I think that part, if you feel better taking a supplement that doesn't have harm, and check with your doctor so it doesn't also interact with your other, but there isn't currently much on the horizon that I think is a promise for strengthening arteries from a specific supplement. Okay, we've got a question from...
We've got another online question. This is Catherine Ashworth, all the way from the UK, the beauty of the live stream.
Yay!
Yes. A female who had her first SCAD at 38 years old, triggered possible extreme exercise and emotional stress, second SCAD at 40 years and 3 months old, postpartum of first child. Thoughts? With question mark.
All right, so for the other live streamers, this was an individual from the UK who had first SCAD at age 38 and then had a baby at age 41, is that right? And
40
had
and 3 months.
40 and 3 months. First SCAD may be triggered by extreme exertion, and 40 and 3 months peripartum SCAD. So a couple of comments. I would have probably advised her not to get pregnant. There were 2 risk factors there, advanced maternal age and prior SCAD. But I would certainly advise no future pregnancies for her. I would advise her, if she hasn't already, to see if she might have underlying condition like an FMD. That might warrant a change, and this would be an individual who I would recommend moderate physical activity and not extreme physical activity. So I think the story is scary, but here's a woman who had 2 SCADs that probably had 2 known triggers, extreme activity. So I'm not sure if she wants to type some more, a follow-up question about what the question really was. I guess what I would say is this is just to reassure her that this is something that we've seen. One of the values of coming together, whether it's online or in person, is the validation of your experience, of your feelings, of your healthcare experience, of a lot of things that others have shared or get. And I think what I would tell her is that she's got a whole room full of people here who get her. Yeah, I've got a.
Is omega-3 found in the inner lining of the heart?
So the question is omega-3 found in the lining or the blood vessels of the heart. So it, among the other types of fatty acids, are found in blood vessels, as there are receptors for all sorts of things, including estrogen. So that's why this is so challenging to sort out, because think about the women and the age who are getting, the hormone levels are all over the place over a period of a month or a lifetime, puberty, young adulthood, pregnancy, menopause. And so better understanding the hormonal milieu, the other triggers that might be are one of those things that we will use both the clinical findings and the clues perhaps from genetic, if there's a gene in a blood vessel that may modify that. Yep.
Do you have recommendations for exercise parameters?
So the question is exercise parameters, and of course those need to be individualized because some people have, chest pain or other things, and the best thing I say is ask that question as you're going through toward the end of rehab so that you can get that. Now, I realize that not everybody goes to a rehab that may have taken care of SCAD patients. So here's what I generally tell, and I don't like setting, you'll hear me, I don't like setting a firm heart rate upper limit. That's kind of artificial because it's very generic, and then you put somebody on a beta blocker or take them off a beta blocker because of the course of their disease, and that changes that. So what I would say is I want people to do moderate physical activity just like everyone else, most days of the week, just like everyone else, because I want all of my SCAD patients to live long and healthy and with healthy bones into the age in which they might be at risk for atherosclerosis, and therefore I want to prevent that. So when I say moderate physical activity, that's brisk walking, that's swimming, that's getting on the elliptical or whatever, and it's not at the high intensity. So I think it's more about the high intensity. So people say, can I run a 10K? I said, if you train, you like to run, you can run a 10K. I don't want you to race a 10K again. We're not looking at personal bests at this point. So things that I advise against, shoveling snow, which you don't have to worry about around here. But it is the time to hire the neighbor boy or get your husband to do it. I advise against high intensity things like CrossFit, where the whole point is walking out feeling like you can barely drag yourself across the floor. That probably is not an appropriate level of exercise for SCAD patients. Bodybuilding and heavy weightlifting, I also advise against, but the caveat is I do want you to do strength training. That's really important, particularly for women who lose body mass as they age and could end up again with osteoporosis and falls. So we're looking at the long haul here, but we're more looking at what is, 5, 10, 20-pound weights with frequent repetitions using good form. We don't want you doing a big... And for those who can't see me, so that Valsalva, so good technique. And, people say, well, my doctor told me never lift anything over 20 pounds or 40 pounds. And I think that's a bit artificial as well. But if you're a small woman, that probably makes sense because you may not be able to lift very easily without kind of straining a 40-pound bag of softener salt, right? Whereas somebody else might be able to. So I think that, I don't know if that answers your question. I think to a certain point it's individualized. I will tell you then some of my patients who've had recurrent SCAD or have extensive FMD, I might make a few more caveats in that regard. But the message is do move. Yeah.
Can you speak to cardiac adjustments, chiropractic adjustments
Yeah.
and massage? I've been told
Yeah.
that I shouldn't have either. So.
Yeah. So the question was, do I have any opinion about chiropractic adjustments or massage? So I think what comes out of that, it has nothing to do with SCAD. However, if we're saying that a lot of SCAD patients may have arteriopathies or weak arteries elsewhere, any concern about abrupt, quick acceleration moves in the neck where the blood vessels are pretty close is of concern. So in terms of a lot of manipulation of the neck with chiropractic, I mean, every one of them has some different techniques, but that would be something you may want to avoid that. Massage, oh, go for it. I mean, seriously, I have not met a massage therapist, yes, who does a lot of time spending massaging the carotid arteries. Yeah. I mean, but tell your massage therapist or your chiropractor that you've had this and have it. But, I think the concerns are, and other people is, roller coasters and things like that. That really has little to do with SCAD, but it does have with the abundance of caution that maybe some of you, even if it's not been diagnosed as a specific artery problem, may have weaker arteries in other places, and it's kind of a theoretical concern. And there's roller coasters and there's roller coasters. I think that old-fashioned wooden roller coaster, there's not a lot of centripetal force. It's just sort of a thrill ride. But there are some, like the Harry Potter ones at Universal and things like that, where you probably, that centripetal force, you might want to avoid. Yep.
With that in mind, do you think that the adrenaline from that thrill is any kind of a concern for someone who's...
So the question is, might the adrenaline surge, the excitement? I guess theoretically, but it sort of depends on how you look at thrill rides. Because some people, they don't. So if you're afraid, this is a good excuse not to go. But if you're somebody who enjoys that, I would say try to get your thrills in a gentler, more controlled one. And yep. Yeah, so that's a great question, and it's one we don't have full answers to, but the question is, say you had a peripartum SCAD, so we're thinking it's hormone related, so what happens when that person then 15, 20 years later is going through menopause? One, I think we'll know a whole lot more in a few years, and so some of the people who are asking me these questions are 20 years from menopause, and I would hope that. But for those of you who may peripartum SCAD or not be near or around menopause, we don't really know, but what I'm advising is that, kind of what I advise any of my female heart patients is that if you don't need hormones for symptoms, if you're not having a lot of hot flashes and others, then I would avoid hormone therapy. If you are having a lot of symptoms, say, and there are women who suffer a lot with menopausal symptoms to the point they don't sleep, they don't work, and then you're talking about a risk benefit. And then I would say we would put people like that We try other things, non-hormonal, because there are some antidepressants, there are some other lifestyle that can be very effective. None are as effective as estrogen. So then if we decide to use estrogen, then typically we'd want to make sure they were on an aspirin. We would use the patch, not an oral estrogen, because that oral estrogen tends to increase. And we would monitor them very closely and use that hormone at the lowest dose for the shortest period of time to relieve their symptoms. So I don't think that having had a SCAD before is an absolute contraindication, because you have to weigh all of the risks and putting some, it's just like people with breast cancer. I mean, we put them in medical menopause sometimes at age 35 or 40, and they suffer greatly. And so we have some experience about non-hormonal uses to manage menopause. But I wouldn't automatically take hormones. I would continue that recommendation. Okay?
An online question from Elizabeth. Is Mirena, I think I'm saying it right, a safe birth control option? You mentioned IUD, but it has hormones.
Yeah, so the question is about the Mirena IUD. So the Mirena IUD is an intrauterine device, so it's a contraceptive that you put in a woman's uterus that makes the uterus a hostile environment for implantation of a baby, and it's highly effective. The Mirena IUD, and I'm not a spokesperson, I get nothing from them, but it has the added advantage is that in people, particularly who have heavy periods, it can actually reduce bleeding after it's been in for a while. So in patients after SCAD who are premenopausal and are having a lot of bleeding because they're taking Plavix, that's an added benefit. The amount of hormones that is in the Mirena is only sort of distributed right there in that immediate, it's right there around where the uterus lining. It is not absorbed. And so we believe, and our OB-GYNs believe, it is probably one of the safer because it's highly effective. And there have been a few publications about Mirena used in a different cardiac, but kind of equivalent population, and that's women with congenital heart disease. So these are women we don't want to get pregnant because they have complex reorganization, and it would be high risk because they were born with an abnormal heart, holes, and may have been, and that was found to be safe and effective. And those individuals also have a number of risks. So there's not been a study on that, but it's generally perceived as safe by most of us. Yep.
GP tells you, oh, you got to have a colonoscopy.
Okay, that's a magical time. So the magical time she refers to is the mid-century mark when your doctor says you should have a colonoscopy. So the first thing is you should have it because you want to prevent other things from taking your life. And since colon cancer is largely preventable, colon cancer deaths anyway, is largely preventable by early detection, it's a good thing to have. Now the caveat there is that any procedure that requires moderate sedation, and that's what, it's not anesthesia, is a risk for somebody. And so and as a result, at least in Minnesota, I think it's a state by state thing, but you have to have had your heart and lungs listened to within the 30 days beforehand. So what we want you to be is stable. Your condition would be stable, and that your cardiologist would say within whatever you have that. Now there are some other options other than colonoscopy. There are two other options. One is a gene test where that's new, that you send your poop off and they look for genes that might be from a tumor. And there are CT colonography, which you still have to do the prep. But and if they find something, you still need the colonoscopy, but it's done as a CT scan. So I think ask your doctor. The gold standard is an invasive colonoscopy, and it's a 1-2 punch because if they actually find a little polyp or something, they can take it out while they're in there. But there are increasing options. You know, there's lots of people who have reasons, but we get people through colonoscopies who have very severe heart disease because we know that they need that too. So.
I have another question about hormones. What do you think about very low dose hormones?
So the question is another hormone question. What do we think about low dose hormones like Vagifem? So Vagifem is made for vaginal use, and it's for women who have pain with intercourse, frequent urinary tract infections. That's what you're referring to, right? Right. So we believe that we know that that is far safer from a hormone standpoint. There is some systemic absorption. It's very, very low, and it's highly effective for the treatment for which it is. And in fact, the national guidelines, not for SCAD, but for treatment of hormones, is if the problem is local, like a woman is having vaginal dryness but not hot flashes, then treat the local problem. In fact, so that is a preferred. So I generally encourage my patients and tell them that it's okay.
E-string, same thing.
Yeah, so E-string is also one of those things where it is low dose and it's localized where the problem is. And I'm going to need somebody, Bob or you, to tell me when you want it to cut it.
And we've got a couple questions, and then we're going to cut off, and then we're going to do a couple presentations. We're going to cut the live stream, and then everybody who's patient, we're just going to do a couple presentations.
Okay. So I'll take a couple more
All right,
questions.
so another question online here. I think it was one that you pretty much answered. I'll go over this quickly. Melissa said, what is the max amount of weight we can safely lift on a day-to-day basis? And I think you addressed that pretty well. And then the next one was, Melissa, Nancy, Andrea, any thoughts on tachycardia, chest pain, and fatigue during periods post-SCAD?
Yeah, so that's a great question. So the question is symptoms around periods. So your doctors may have said they've never heard of that, if you have it. But in fact, there's been some evidence published for years that there is actually a variation in the cycle, meaning in menstrual, so there's premenopausal women, in the frequency of supraventricular tachycardia, which is a rhythm, and they showed that women over their different parts of would have different frequencies as the cycle went on. And it varied by the levels of hormones. So it doesn't take much of a stretch to say there's different milieu and that some people might have some changes. And remember I said there's estrogen receptors on every blood vessel in your body. So in individuals who have more symptoms during certain parts of their system, I work them up for their chest pain just like I would anybody else. I want to make sure they don't have a blockage. So I'll do a stress test. But often, going back to that chest pain postpartum, I have a few patients in my practice who only use their calcium channel blocker or their long-acting nitrate in that 2 to 3 days that they can predict that they're going to have symptoms. Others take it around. But I think important that we make sure that it's not chest pain that might be due to something else, and then I think working with your doctor to manage it. All right?
Yeah, there's one more. One more.
Okay, and there's one more in the room, I think, but
All right, one more from online. Melissa says, is it common to have a coronary artery spasm shortly after having SCAD in the same artery?
the answer, so the question is, for the rest, is might there be coronary artery spasm around the same time as a SCAD? And the answer would be yes, because you've got a damaged artery that's irritable and may spasm down, which is why often in the hospital you will be given nitrates and calcium channel blockers for that. And I will take one more question.
Do you have any advice for improving relationships with a cardiologist, or for educating them without them getting defensive, or like my refuse this rehab? I've asked for it and did not.
So the question is, do I have any advice on how to work with your cardiologist? I've been giving advice to women advocates about how to work with their cardiologist for more than 2 decades. Because we're a referral center. I don't care for all of the patients who come see me once. I have a number of patients that I'm their primary cardiologist, but a lot of them go back. And I think there's certain things that, and I was saying this individually, so just some high-level things. So one is people say, well, my doctor says I love him, but he don't know anything about SCAD. But he works with me and he listens to me. And I said, you keep that guy. Go to somebody, get your SCAD information, because that's probably also somebody who's going to reach out, going to continually evolve in his learning, and will apply that to patients as he learns it. So first of all, I think you can learn about SCAD from reading our papers, from doing things as we go. You can't learn to be a good doctor. and patient. That takes work, and probably at the stage of the career you're going. So if you've got one who won't talk, won't listen, or tells you he or she knows everything about whatever they know, that's probably the time to start the research on getting a different one. I'm not saying to drop them, but if you have options. And I realize not everyone, because there may just be one cardiologist within driving distance or within your network. I recognize that as an issue. The rehab thing bothers me a lot, because rehab is absolutely, there's a guideline by the American, that's by the American College of Cardiology and AHA that says after heart attacks, people should go into cardiac rehabilitation. So that would be another reason, whether you want to learn to communicate with him or start thinking about somebody who's following our national guidelines. So there's a communication part, but there's also a quality part. And cardiac rehabilitation, you heard me start with that, it's a quality metric. So.
I'd like to thank Dr. Hayes and Dr. Thies for today, for coming and speaking to us. I think they did a wonderful job. Thank you very much. I'd like to thank everybody online. We had over 50 people online. This will be recorded and dropped, I think, in a couple days, so you can look at it again if you'd like. And we're going to shut the live stream, and then if you give me a couple minutes, I just would like to do a couple things. So are you shutting it down?
I will be.
Okay.
Thanks, everybody.
Okay. So one of our